Hydrocephalus is a disorder where there is an excessive amount of the cerebrospinal fluid that accumulates inside the cerebral ventricles as well as the subarachnoid space. So the word hydrocephalus means water, so hydro means water, and then cephalus means brain, so water in the brain. And this condition arises as a consequence of imbalance in the production and outflow of the cerebrospinal fluid. Now there are different forms of the hydrocephalus that are listed here, and then there are also other conditions like Dandy-Walker and Arnold-Chiari syndrome, which are associated with dilated or compression of the fourth ventricles. So what I'm going to do is that first I would like to describe the normal physiology of the cerebrospinal fluid production and then discuss the anatomy of the cerebral ventricles, after which it would become very easy to understand the mechanism of pathogenesis of these disorders. So cerebrospinal fluid, it's being produced by the choroid plexus, and in order to be more specific, it's the ependymal cells of the choroid plexus that produces the cerebrospinal fluid. And these cells are dependent on an active transport system that uses the enzyme carbonic anhydrase. And so therefore, if a patient has elevated intracranial pressure and we want to decrease the production of cerebrospinal fluid, we can provide these patients with the acetazolamide, which is a form of diuretic that inhibits the carbonic anhydrase enzyme. As a consequence of which, now that carbonic anhydrase is inhibited, ependymal cells can no longer produce cerebrospinal fluid, as a consequence of which the intracranial pressure will start to drop. So once again, the cerebrospinal fluid is being produced by the ependymal cells of the choroid plexus, and these cells are dependent on the function of the carbonic anhydrase enzyme. And so if we provide patients with acetazolamide, since the carbonic anhydrase enzyme would be inhibited, the production of cerebrospinal fluid will be decreased, as a consequence of which now there would be decreased intracranial pressure. Now, as for the circulation of the cerebrospinal fluid, most of the cerebrospinal fluid is being produced inside the lateral ventricles as well as the third ventricle. So the startup of the CSF would be inside the lateral ventricles. So we have one here and then one we have at the back there. And then via the foramen of Monro, which is right here, cerebrospinal fluid would be able to be transported from the lateral ventricles into the third ventricle. So this is the foramen of Monro. Here we had the lateral ventricles, and then this one is the third ventricle. And then from here on, cerebrospinal fluid will flow from the third ventricle into the fourth ventricle via the cerebral aqueduct of the sylvius. So this one is the cerebral aqueduct of the sylvius that will connect the third ventricle to the fourth ventricle. And then from here on, the cerebrospinal fluid will flow into the subarachnoid space via the foramen of Luschka as well as foramen of Magendie. And if you ever confuse which one is which, the way you can memorize it is that foramen of Magendie is in the midline, so foramen of Magendie is in the midline, while the foramen of Luschka's, where there is two of them, are lateral. So Luschka is lateral, while foramen of Magendie, where there is only one of it, is in the midline. Alright, now to review all these findings one more time. So the cerebrospinal fluid are being produced in the ependymal cells of the choroid plexus of the lateral ventricle. From here on, they will be transported into the third ventricle via the foramen of Monro. And then they will be transported from the third ventricle to the fourth ventricle via the cerebral aqueduct of the sylvius. So here we had foramen of Monro, and now here we have the cerebral aqueduct of the sylvius. So cerebral aqueduct of sylvius. And then from the fourth ventricle via the foramen of Luschka and foramen of Magendie, they would be transported into the arachnoid space. And then from the subarachnoid space, they would be transported into the superior sagittal sinus via the arachnoid villi. And so with that information in mind, now we can go ahead and review different forms of hydrocephalus. So the first two forms of hydrocephalus, non-communicating and communicating hydrocephalus, these are more common in children and are associated with elevated intracranial pressure. On the other hand, the other two hydrocephalus that I will discuss next are more common in adults, and then these two forms of hydrocephalus, the hydrocephalus ex-vacuo and normal pressure hydrocephalus, have a normal intracranial pressure. In any case, back to the forms of hydrocephalus that are more common in children. So these forms of hydrocephalus are associated with elevated intracranial pressure. The first form is a non-communicating hydrocephalus, also known as obstructive hydrocephalus, and the reason this name is given to it is that the ventricles of the brain cannot communicate with each other. So some sort of obstruction prevents the communication between the brain ventricles. And the most common site that is being affected is the cerebral aqueduct of the sylvius. And the reason for that is that this cerebral aqueduct has a narrow structure. So you know how this cerebral aqueduct has a narrow structure, and so thus it's at increased risk of being obstructed and cause non-communicating hydrocephalus, where the third ventricle and the fourth ventricle can no longer communicate with each other. And so now you can imagine that if the fourth ventricle is being obstructed, the findings that you see is dilation of the third ventricle as well as the dilation of the lateral ventricles. So let's go back here to non-communicating hydrocephalus. So usually it's the cerebral aqueduct of the sylvius that is being obstructed, as a consequence of which it will cause increased size of the lateral as well as the third ventricles. And then the condition that usually causes obstruction of the cerebral aqueduct of the sylvius is the tumor of the ependymal cells, which is also known as ependymoma. And so this type of tumor can arise in the fourth ventricle, as a consequence of which it will block the fourth ventricle and cause non-communicating hydrocephalus. The next condition is communicating hydrocephalus. So this form of hydrocephalus, there is a normal communication between the cerebral ventricles. But now the problem is the impaired absorption of the cerebrospinal fluid from the arachnoid villi. And it's usually conditions that cause inflammation of the arachnoid villi, like for instance meningitis, that are the underlying cause of the communicating hydrocephalus. Now you can imagine that if none of the cerebrospinal fluid is being absorbed, therefore it's all of the ventricles that are being affected. So here we will have dilation of the fourth ventricle, dilation of the third ventricle, as well as dilation of the lateral ventricle. So once again, since the cerebrospinal fluid is not being absorbed in the arachnoid villi, now we will have dilation of the third, fourth, as well as lateral ventricles, compared to the non-communicating hydrocephalus, where it was due to the obstruction of the cerebral aqueduct, we only got dilation of the lateral and third ventricles. In any case, the findings that you see with the non-communicating and communicating hydrocephalus include, for instance, increased intracranial pressure, headache, as well as papilledema. And I would like to describe papilledema in a little more detail. And so here on the left side of the image, we have a normal fundoscopic examination, where here we have the optic disc, and then at the center we have the optic cup. And the normal ratio of the cup to disc is usually about 0.3, but in patients that have glaucoma, the optic cup will start to grow in size. And so you usually will see very narrow space between the optic cup and the optic disc. And so this condition is referred to as glaucoma, which means that there is an elevated pressure inside the eye. So with glaucoma, there is an increased pressure inside the eye, which will push on the optic disc and make it larger than it normally is. Versus the image in the right, where there is an optic disc swelling, the other name for which is papillary edema. And so here you can see that it's as if you're looking from the top on a volcano crater. The pressure inside the brain is so high that it will push on the optic nerve, and so you can see that these edges has been raised. So you cannot really see the optic disc here any longer with the optic disc swelling. So with this condition, papillary edema, there is an increased intracranial pressure which will push from behind the retina, from inside the brain. It will push behind the retina and push this optic disc outward. And then versus the glaucoma, where there was an increased eye pressure, and so the optic disc has been enlarged in size. So that's the difference between the images that you see with glaucoma compared to the papillary edema. And so with patients that have the communicating or non-communicating hydrocephalus, in addition to the elevated intracranial pressure, they also present with headaches as well as papillary edema. The next condition is normal pressure hydrocephalus, which is more commonly seen in adults, and as the name implies, it's a normal pressure. So intracranial pressure is normal in these patients. And the exact etiology of this disorder is not known. It's not known how ventricles will enlarge in size, but then intracranial pressure remains normal. But in any case, due to the enlargement of the ventricles, it will disrupt the fibers of corona radiata. And so due to the disruption of the fibers that are being projected from the brain, these patients generally present with urinary incontinence. They present with gait disturbances, and then they also present with dementia. And this is an important triad that you have to be familiar with: urinary incontinence, gait disturbances, as well as dementia. And so the memory aid that I have for you is called wet, wobbly, and wacky. So patients that have normal pressure hydrocephalus are wet due to the urinary incontinence, are wobbly due to their gait disturbances, and then finally are wacky due to their dementia. And then if you're curious in terms of the treatment of what can be done for these patients, you can consider ventricular shunting. And then the alternative option is repeated spinal taps. The next and final form of hydrocephalus is called hydrocephalus ex-vacuo, where there is dilation of the ventricles secondary to brain atrophy, which can be, for instance, from trauma, Alzheimer's disease, or surgery. And so once again, the intracranial pressure is normal in patients with hydrocephalus ex-vacuo. Alright, now we can move on to the other two developmental anomalies, the first one of which is the Dandy-Walker syndrome. So this condition arises from the failure of foramina of Luschka and Magendie to open. And so now tell me, if these foramens fail to open, which ventricles would be dilated? And so the answer would be that it would cause dilation of the lateral, third, as well as the fourth ventricles. And so with the dilation of the fourth ventricle and the enlargement into the posterior fossa as a cyst, it would cause hypoplasia and sometimes agenesis of the cerebellar vermis. So here you can see that there is agenesis of the cerebellar vermis in patients that have Dandy-Walker syndrome. So the two important findings in patients that have Dandy-Walker syndrome is that due to the failure of the foramen of Luschka and Magendie to open, patients present with dilation of the fourth ventricle as well as agenesis of the cerebellar vermis. The next condition is Arnold-Chiari malformation, where there is a downward displacement of the inferior cerebellar vermis, cerebellar tonsils, as well as medulla through the foramen magnum. So here you can see that we have a normal anatomy, and so on the image in the right we have Arnold-Chiari syndrome, where all these structures have now displaced downward into the foramen magnum, as a consequence of which it will cause compression of the fourth ventricle. So you can see how fourth ventricle is normal in this image, while in the image on the right the fourth ventricle has been compressed. So therefore one of the features of Arnold-Chiari syndrome is compression of the fourth ventricle, as a consequence of which it will cause obstructive hydrocephalus. And then it has been shown that these patients are frequently associated with having Meningomyelocele as well as Syringomyelia. Now the forms that I just discussed with you is type 2 of the Arnold-Chiari malformation, so this was type 2. There is also another form called type 1 Arnold-Chiari, which is only associated with downward displacement of the cerebellar vermis, and this condition is generally asymptomatic. Alright, now that we are done with the review of all of these conditions, we can go back through these tables and then summarize all the findings. So the first condition is non-communicating hydrocephalus, where the ventricles inside the brain cannot communicate with each other due to the obstruction that is going on, and it's usually the cerebral aqueduct that is being affected, and it's due to the tumor of the ependymal cells known as ependymoma. The next condition is communicating hydrocephalus, where there is an impaired absorption of the cerebrospinal fluid in the arachnoid granulations, which usually results from conditions that cause inflammation of the meninges, like for instance meningitis. And so therefore patients generally present with elevated intracranial pressure, papilledema or optic disc swelling, headaches, as well as herniations inside the brain. And then if you're curious what can be done in terms of the treatment of these conditions, we can provide some sort of the mechanical shunt which directs the cerebrospinal fluid from inside the ventricles into the systemic circulation. The next condition is the normal pressure hydrocephalus. So while the first two was associated with elevated intracranial pressure and was seen in children, the other two conditions that I'm going to discuss were more common in adults and are associated with the normal intracranial pressure. So as just the name implies, normal pressure hydrocephalus. And so with the normal pressure hydrocephalus, its exact etiology is not known. It's thought that it may be a kind of the communicating hydrocephalus where the cerebrospinal fluid is not absorbed, and so it will cause dilation of the ventricles. And so since it's disrupting the fibers of corona radiata, these patients present with the dementia, ataxia, and urinary incontinence. So once again, wet, wobbly, and wacky. So patients will have urinary incontinence, will have ataxia, and will have dementia, wet, wobbly, and wacky. And then finally, the last condition is hydrocephalus ex-vacuo, where there is an excess cerebrospinal fluid in the ventricles, and this is due to the brain atrophy, which could be from, for instance, trauma or condition like Alzheimer's disease, which causes atrophy of the brain. The next two malformation disorders are Dandy-Walker and Arnold-Chiari syndromes. So Dandy-Walker is due to the failure of foramina of Luschka and Magendie to open, as a consequence of which it will cause dilation of the fourth, third, as well as lateral ventricles. And then the associations that you see with the Dandy-Walker malformation is the cerebellar malformation, as the fourth ventricle can turn into a cyst and then cause agenesis of the cerebellar vermis. On the other hand, Arnold-Chiari malformation, the type 2, is associated with downward displacement of the cerebellar vermis, medulla, as well as the cerebellar tonsils through the foramen magnum, as a consequence of which they would cause compression of the fourth ventricle, and so therefore these patients present with the communicating hydrocephalus due to the compression of the fourth ventricles. And then the other conditions that you may see with the Arnold-Chiari malformation includes the Meningomyelocele as well as Syringomyelia. And so the last point that I would like to mention is that here I have provided you with a memory aid to remember that Dandy-Walker syndrome is associated with the dilation of the fourth ventricle, while the Arnold-Chiari syndrome is associated with the compression of the fourth ventricle. So once again, Dandy-Walker causes dilation of the fourth ventricle, while Arnold-Chiari causes compression of the fourth ventricle. And that concludes our discussion of the hydrocephalus as well as Dandy-Walker and Arnold-Chiari malformations.